Hello, everyone, and thank you for this wonderful opportunity to present at this meeting. In the next very short while, I'm going to be reviewing, I think, a great deal of material on a subject that I've been writing about for the better part of the last few decades. I'm going to be talking to you about dignity therapy, and I've called this talk Dignity Therapy, Setting the Foundation. Perhaps before getting too far into my remarks this morning, I will tell you that I'm speaking to you today from Winnipeg, Canada. Winnipeg is the capital city of Manitoba. We're located right in the center of the North American continent. And this is a landscape photograph of Winnipeg. This particular magnificent building is the Canadian Museum of Human Rights. And I put it up both because of pride for my hometown, and as well to say that over the last couple of years, until the pandemic, that is, this is where we've been holding our annual dignity therapy training workshops. Now, my entry into palliative care research, and this is research that led directly to dignity therapy, actually begins with this paper. This paper was published in 1986 in the American Journal of Psychiatry, and it was an article by Dr. James Brown and colleagues about whether it is normal for terminally ill patients to desire early death. In this small but important groundbreaking study, they screened 44 terminally ill patients. They discovered that 10 of them had a genuine desire for death to come early, and at the same time reported that all 10 of them experienced concurrent major depression. So our research group started to assemble itself and say, is it possible that there are other things besides depression that might explain whether or not somebody's will to live or wish to go on living waxes and wanes towards the end of their life? And so we began doing a series of studies, the first of which appeared again in the American Journal of Psychiatry, called Desire for Death in the Terminally Ill. And while the details aren't important, what is important is that we looked at over 200 dying patients. We measured desire for death in the terminally ill, reported that approximately half of them never had such a desire, which means that in the remaining few, the wish to die is not an atypical event that can occur amongst people who are nearing death. And in a small group, 7.5 or 8.5%, these are people who had a genuine desire to die. They weren't necessarily making outright requests for euthanasia or assisted suicide, but simply expressing the fact that they would be content if their lives were over sooner than later. And so we then divided this group between those with a desire for death versus those without a desire for death to try and get a handle on what were some of the drivers of desire for death in people who are approaching death. And as you would expect, pain was a significant player. So 80% of patients with a genuine desire for death had pain that was of moderate severity or greater. They had a perception that their family support was not as available. And then we also found that depression turned out to be a key player. The prevalence of syndromal depression amongst those who had a desire for death was somewhere in the magnitude of about 65%, compared to only somewhere between 6 to 7% prevalence of syndromal depression, sorry, a little stall there, syndromal depression amongst those who did not have a desire for death. So 65% or so compared to 7% desire for death versus non-desire for death, a substantial difference. But what we also discovered is that if you start to look at desire for death, or what we called will to live, you can see that will to live is something that fluctuated greatly over time. So this is a woman with end-stage colorectal cancer. She's an elderly woman. When she first enters into our studies, you can see that her will to live is actually poor. It improves. So as the score goes down, it reflects an improvement in will to live. And then towards the end of her life, will to live becomes much more erratically reported. And again, this is a study that we published in the Lancet many years ago now. When we looked at this particular case example and we superimposed her experience of pain along with will to live, what you can see is that pain and will to live do this incredibly intimate dance, a tango, if you will, thinking about today's audience. And what you can see is that pain and will to live do this intimate dance with one another, such that as will to live improves, it appears so too does pain. Or it could be that as pain improves, will to live starts to improve. So we can't necessarily talk about causality, but we can say that these two things are intimately related to one another. As we explored the details of our findings, I mean, what we found is that there are many things, and likely many existential factors, that we hadn't even begin to anticipate, that starts to influence whether life continues to be worth living for people who are approaching death. And this kind of thinking and this kind of consideration got us looking towards the experience of what was happening in the Benelux countries, where euthanasia and assisted suicide was being practiced quite openly for some time. And what we discovered is that when you started to look at empirical data coming out of places like Holland, that loss of dignity, according to Dutch patients, was the reason, more so than anything else, why these patients had sought out either euthanasia or assisted suicide. You can see pain alone was not a big factor. Pain is part of a constellation of other symptoms, 49%. And then these things that were really quite vaguely described and not really carefully defined: unworthy dying, being dependent, tiredness of life. But this finding, loss of dignity, is really the thing that got dignity on our clinical or research radar, if you will. And this is the pathway that led us, I was going to say directly, but perhaps somewhat indirectly, to developing and then testing this unique psychotherapeutic intervention that I'm going to be talking about today, called dignity therapy. When we did some of our first studies on dignity, again published in the Lancet, we saw that according to just over 200 dying patients, about half of them never had a loss of sense of dignity, which means the remainder did, and 7% had a genuine or significant problem with respect to the issue of dignity. Again, when we divided the group between those whose dignity was intact versus those whose dignity was fractured, what we found is that when you lose your dignity, you're more likely to lose your desire for death, or to have a desire for death, I should say, to lose your will to live, to experience depression, hopelessness, and anxiety. You're more likely to experience physical symptoms such as pain, difficulty with toileting, or changes in your perception of your physical appearance. These intimate dependencies of care, bathing, dressing, incontinence, these are things that were much more likely to be reported as problematic amongst patients who had a genuine lost sense of dignity. And then this wonderful etching by M.C. Escher, when we looked at what is it that predicted more so than anything else lost sense of dignity, it turned out that the variable appearance, or how people perceive themselves to be seen. And years later, I discovered this etching by Escher, in which it's a self-portrait. And you can see that what Escher has portrayed here is an image that is reflective of who he is in his entirety. I like to think of this as dignity in the eye of the beholder. In other words, this is the reflection that patients want to see metaphorically in the eye of the healthcare provider. It's not a problem checklist. It's not a differential diagnosis. It is the entirety of that individual's personhood. So there are pictures, there are photographs and belongings, all of this attesting to the fact that I am a whole person. I am not just a patient, but I am a whole person. And this kind of insight was the foundation or the basis of what I, in my writings, have called dignity conserving care. To understand dignity conserving care, I turn to a qualitative study that we reported a number of years ago in Social Science and Medicine. It was also reported in the Journal of the American Medical Association, JAMA. And what we showed, again, this is an empirical model, so we enrolled patients, spoke to them about dignity and how they understood it. And you can see that according to dying patients, there were some things that were mediated by the illness itself. There were some things that we called the dignity conserving repertoire. These have to do with the psychological and spiritual aspects of who that individual is. And many of these things had to do with personhood. And I'll get back to that in a moment. And the final thing is something that we call the social dignity inventory. This is recognizing that there are things that can happen to that individual. There are things in his or her environment that can support or undermine dignity. And the one that I'll point you to is care tenor, or the tone of care. This has to do with qualities about you, not necessarily what you're saying or doing, but an aura about you. At one time, an oncology nurse that I was giving this talk to called it the fragrance of care. It's that something that patients are able to sense from you that says to the patient that you care, that you are curious, you're available, you are giving unwavering attention, and therefore providing the appropriate care tenor to support dignity. Going back to the dignity conserving repertoire, the one thing that I wanted to point out was something called generativity or legacy. So for some patients, what we discovered is that this ability, and this is taken from work by the developmental psychologist Erik Erikson, the ability to know, or the knowledge of knowing that something of who you were will have ripple effects even beyond the event of your death. So your life will have an influence that's transcendent of death. This is the notion of generativity, that what you have done can or will influence generations that follow in your wake. So understanding the model and understanding dignity therapy means contemplating how can we change the healthcare provider lens so that we're able to see the totality of who our patients are as persons, and not allowing patienthood to overshadow or to usurp personhood. So again, thinking about this model gives us a map, if you will, and it's a map of how to achieve dignity at the end of life. So can we use this map to influence or shape a dignity conserving intervention? And this is what we try to do in our work over the last couple of decades. So to develop dignity therapy, we knew that generativity was important, that people would be engaged in a brief, individualized talking therapy that would be recorded and transcribed, edited, and then returned to the patient for him or her to bequeath to their family, their loved ones. So something of what they said would be lasting. Beyond the event of this conversation, this document will have a life of its own, that will transcend even this life itself. What do people talk about? Well, we think about the dignity conserving repertoire, and it's about maintaining pride, role preservation, maintaining hope, which really for the terminally ill means finding meaning and purpose. And the tone of dignity therapy is going to have the appropriate care tenor. It's going to be non-judgmental, it's going to be supportive, and open and available to all that the patient may want to say or convey. So perhaps the best way of telling you what dignity therapy looks like is to describe the first patient that I did dignity therapy with. And this was a man in his late 60s. He had an advanced colorectal cancer, and he had gone on a hunger strike. He felt that life was no longer worth living. To use his words, breathing had become redundant. So I went into his room. I did a psychiatric evaluation and determined that he was not suffering from any psychiatric syndrome per se, but nevertheless had, the usual struggles that people face as they're approaching end of life that really reside in the realm of the spiritual and the existential. And so I spoke with him and I explained this new therapeutic innovation that our group was developing called dignity therapy. And if he was interested, I would come back and guide him through a conversation in which he would share various aspects of who he was, tell his story, share his hopes, wishes, or dreams, and so on. I would record that conversation. I would transcribe it. I would bring it back to him as quickly as possible. As you see, there's sort of this sense of immediacy. If your words matter, then we need to move quickly on developing this document for you to have, to hold, and to bequeath to your family. So he listened to me. And by the way, when I had walked in the room, he had intimated, he had said that if he could push a button in a European country to end his life now, that he would. And you know exactly what he was referring to. He was talking about pressing a button so he could die. After I explained this to him, and he had agreed that he wanted to do it, before I left his room, I said, so by the way, would you still want to press that button? And he looked at me with this sort of sheepish smile, and he said, well, no, I want to do this first. And to me, it was like palliative care penicillin. Like, isn't this extraordinary that in this brief interchange, this man now feels like he has a sense of meaning and purpose. There is some reason for him to live, so he can create a document that can safeguard the well-being of his family. So I came back within a few days. I sat down with the tape recorder. We had a wonderful conversation about his families, his children, the untimely death of one of his children, the great successes of his other daughters, his wishes and hopes for his now aging wife and how he would want her to live out her final days. It was magnificent. We recorded it, we transcribed it, we did some minor editing. There wasn't much that needed to be done. By the time we came back to his bedside, he was too weak to take it from me. His wife knew all about this. She received it from me and said to me, this will be a blessing to our family. So since then, I've done a great deal of work on dignity therapy. I've written a book on dignity therapy called Dignity Therapy, Final Words for Final Days. There are a number of translations. I don't believe there is a Spanish translation as yet. I could be wrong, but I do not believe there is a Spanish translation. And we also began doing additional trials, including a randomized control trial. When you think about dignity therapy and the steps, what we need to do is find out, is somebody eligible? So are they interested in creating a generativity document? And are they competent to answer questions and to be able to provide informed, fulsome responses? We explain it to them. We share with them the dignity therapy question framework, and I'll share that with you as well. It's also, all of this is available online without any cost whatsoever to the patients or to you if you're a therapist. We obtain what I call a framing interview, which is basically to find out, who are you doing this for? What are your goals in creating this document? So if you know who you're doing it for and what they intend to create, it makes it much easier for you to create the document. The last gentleman I did dignity therapy on, and this was just last week, he ended up telling me that he had married and divorced 4 times. Later on in life, it was discovered that he had bipolar disorder. Once he was treated, his life turned around. And basically, what he was doing dignity therapy for was to offer an apology to the many people that he had hurt because of the chaos of what his life was like with uncontrolled bipolar disorder. You arrange for a dignity therapy session to take place, and you conduct the therapy as quickly as possible so that people aren't kept waiting. There's then an editing protocol, which again turns this wandering dialogue into a more pristine narrative. There's then a follow-up in which, again, as soon as possible, we meet with the patient, we read the document, we make any corrections that are required, and then we turn the document over to them, providing them with a final generativity document. The questions that we ask of patients are the following. And again, because of time, I'm not sure I'm going to read through all of them, but, and again, they're all available online. You know, asking about the things that are most important from your history, things you would want your family to know about, special roles, accomplishments, things you feel you still want to say. What are your hopes or dreams for your loved ones? What have you learned from life? What is the wisdom that you would like to pass along? Perhaps even instructions you might like to provide them. So again, I understand that this is moving quickly, but all of this is available online. Just type in dignity therapy or go to dignityandcare.ca and look under tools, and you'll find all of this information available. When we did some of our first studies on dignity therapy, and this was a study of 100 dying patients divided between Australia and Canada, you can see that the vast majority were satisfied. They found it helpful. They believed it improved their sense of dignity, increased their will to live, and the majority said that it would or had been of help to their family. Interesting, when we met with family members after the death of their loved one who had received these documents, they all felt that it helped their dying loved one, you know, prepared them for death. They, you know, 65% said it was as helpful as anything that had been done on behalf of their now deceased loved one as anything else in palliative care. And also, it was a bereavement intervention. They felt that it helped them during their time of grief, that it continued to provide comfort to their family, and 95%. So nearly everyone said that they would recommend it for other family members who were going through something similar. We did randomized controlled trials of dignity therapy. I can tell you that now there have been nearly 100 papers published on dignity therapy. About 25 to 30 of them provide unique data on dignity therapy. This is a very messy slide, but I just included, I think these were 7 systematic reviews that I can find that have been published on dignity therapy. And essentially what they all say is that dignity therapy is a reasonable way of enhancing quality of life and improving end-of-life experience for dying patients. What the studies have found is that depending on the outcome measure and depending on the audience in which it's being implemented in, for example, if patients are highly distressed, dignity therapy has been shown to mitigate depression, desire for death, demoralization. In other cohorts, it has been shown to improve sense of dignity and, as I said, improve end-of-life experience. I mentioned there being over 100 papers that, again, it seems like the more distressed the audience is, the more likely it is to mitigate that kind of distress. In some audiences, it seems, or cohorts, it seems to enhance death acceptance. And also has, as I said, shown to be of benefit to family members. There have been a number of dignity therapy trials and knowledge translation events that have taken place, clinical trials in all of these countries that you see listed here, and training in a variety of settings. And by the way, I should also, I noticed that Spain isn't on there, but there was a training dignity therapy module that took place many, many years ago in Spain. So with that, I'd like to thank all of you for this wonderful opportunity of presenting dignity therapy. It's wonderful that through platforms like this, we are able to meet virtually. The pandemic has been such an extraordinary tragedy in our lives. If there's one silver lining, it's that we have been able to connect with each other in ways virtually that are in some ways unprecedented. And I can say that during the pandemic, I have been delivering more dignity therapy than ever before. Again, thank you for this opportunity, and I look forward to your questions and comments, and I wish you all the very best. Thank you.